So, nutrition and public health part two, understanding malnutrition and various nutritional disorders. So basically, this is not a topic that you people are not aware of. This is not some out of word kind of thing. This is not some weird kind of mechanical thing or some advanced electrical engineering subject. It's not like that. Nutritional disorders or the basic knowledge of nutrition. Majority of us already know, or maybe all of us already know from our high school times or from our intermediate levels, and even when we started taking formal education, there are some subjects which cover the topic of nutrition and what is the benefit of nutrition, what is the importance of nutrition, and what are the problems associated with malnutrition, various nutritional disorders. So basically, we this in this lecture we will understand the concept of malnutrition and various nutritional disorders. So I will not be able to cover all of the nutritional disorders in this lecture because this is a very vast subject and it needs a lot of time. And there are a lot of nutritional disorders which need to be covered. But we will cover protein energy malnutrition in detail and the guidelines about the basic management. I will not go into the details of how to manage a sick child in hospital because that is the subject for hospital care staff, but we will guide about we will talk about the basic management of a child having acute malnutrition or severe acute malnutrition. So the learning objectives for today's class are introduction, brief summary of previous class, then basic definitions, understanding the concept of malnutrition. Then whenever we talk about malnutrition, it means either overnutrition or undernutrition. Malnutrition means not having healthy or beneficial diet. So it might be overnutrition or undernutrition. So the fifth point will be overnutrition and its hazardous effects, then undernutrition and its subforms, protein energy malnutrition. Some people also call it protein calorie malnutrition, but the modern term is protein energy malnutrition. So I will use the term PEM, protein energy malnutrition. I will not call it PCM. Various clinical syndromes of protein energy malnutrition. Then, the most importantly, approach towards a child with severe acute malnutrition.
Dr. Omer, can I ask a quick question? Your
Yeah.
previous class, was it about 2 or 3 weeks ago, called Understanding the Basics of Nutrition and Healthy Foods?
Yeah.
That was part one?
Yeah,
That
it
was
was
part
like,
one? Okay, because I'm going to put the
yeah,
link
that
up
was
to that.
part
Some of the students are asking the link to part one, so I'm going to put up that link.
one. Yeah, you can put up that link, and I already shared the presentation file with the university administration.
Thank you.
Yeah, you can share the link. Thank you, sir. Should I continue?
Yes, please.
Okay, thank you, sir. Okay, so various clinical syndromes of PEM, then there is approach towards a child with severe acute malnutrition. So basically what I taught in part one of our lecture series, most of you people already know those things, but this is not my way to teach things. I cannot go on to teach about the disease of something if I haven't taught the basis of that thing. So without giving my concept to my students about what nutrition is, I could not start talking about malnutrition. If I am unable to teach my students what are healthy foods and what is the meaning of good nutrition and what is the basis of good nutrition, then I think it's unethical on my part to start teaching about the advanced subjects. That's why part one was necessary on my behalf. So I went into details as much as I could go in 1 hour. In 1 hour, I find it limited time. So in 1 hour, as much as I could go into the details, I went into the details of what actually nutrition is. Many of you must have read these things, and some other teacher must have taught you these things as well at high school levels or at college levels as well. But I felt an obligation to teach all of you about what nutrition is. Now, this is what our basic topic is. Our basic topic is nutrition and its uh, interaction or its relationship with public health. So our basic topic was not introduction to the nutrition. You all of you know what is nutrition is. Our basic topic is introduction to the nutrition and the effects of healthy diets or nutrition with public health, as well as malnutrition with public health. So basic topics, what our basic topics is, that is what we are gonna study today and onwards in our part three of this lecture series, which I will teach later. So, approach towards a child with severe acute malnutrition. So, all of these things are related with public health. So, if we are not having good nutrition, what will happen to our children? What will happen to the people who are not having good nutritional status? So, basically, if a person is having a good nutritional status, then what will happen to his health? And if a person is not having good nutritional status, he is not having good foods and is not having a healthy lifestyle and he's not taking healthy diets, what will happen to that person, especially children? So, introduction. As discussed in previous class, we are what we eat. At the most basic level, the concept of having a good nutrition means eating a regular, balanced diet, as nutrition is the thing which keeps our body systems running optimally all day long. The foods we eat supply our body with the needed nutrients to maintain our body, muscles, bones, nerves, skin, blood circulation, and all the organ systems and immune system. Proper nutrition also helps us protect from illnesses and many diet-related diseases. So, brief summary of our previous class. In the previous class, we discussed the topics of process of nutrition, understood the concepts of foods and nutrients, classification systems of foods. There are various classification systems of foods which we already discussed in the previous class. I will not go into the details. So, macro and micronutrients, then macro and micronutrients, then the concepts of balanced diets were discussed in detail. Finally, relationship between nutrition and public health was discussed briefly. I did not go into the details of nutrition, the relationship between nutrition and public health, but we did discuss it briefly. So, what are the important definitions? We already know nutrition. Nutrition is the process of taking in food and converting it into energy and other vital nutrients required for life. In the process of nutrition, our organism utilize nutrients. Or the nutrition is the assimilation by living organisms of food materials that enable them to grow, maintain themselves, and reproduce. Similarly, nutrients are the substances essential for growth, maintenance, function, and reproduction of a cell or an organism. The absence or deficiency of any of these may result in poor health or disease of organism. Then there is undernutrition. Undernutrition is defined as low weight for age, low height for age, and low weight for height in children or adolescents. And chronic energy deficiency is the condition of being underweight among adults as the result of prolonged negative energy balance. BMI value of less than 18.5 indicates CED in adults. Then there's the concept of kilocalorie. All of you must know. I did it in our previous class as well. It is the amount of heat required to raise the temperature of 1 liter of water by 1 degree Celsius. So 1 kilocalorie is 1,000 calories. And what is BMI? Most of you already know it is a ratio of weight for height of an individual, which is often used to estimate body fat. It is obtained by dividing the weight in kg by square of height in meters. We will discuss the formula later in this class. So, this is our basic topic for today's class, understanding malnutrition. This section will elaborate the topic of malnutrition and its various subforms. So, all of you can easily spot this is a picture from Yemen, as there is already a civil war going in Yemen. So this is a Yemeni child suffering from severe malnutrition. This child is suffering from a mixture of marasmus and kwashiorkor. It's not a truly marasmic baby as well as not a truly kwashiorkor baby as well. So whenever a child is suffering from a mixture of marasmus and kwashiorkor, that child is even difficult to treat than the one who is suffering from marasmus alone or kwashiorkor alone, because that child is not only suffering from protein energy malnutrition, or not only suffering from protein deficiency, but that child is extremely sick in all of the calories, including carbohydrates, fats, vitamins, and minerals, everything. So malnutrition. Malnutrition is defined as pathological nutritional state of any individual resulting from deficiency or excess of essential nutrients. So malnutrition is defined as pathological nutritional state of an individual resulting from deficiency or excess of essential nutrients. So you cannot call the deficiency as malnutrition. It can also be called as excess of essential nutrients, which can be termed as malnutrition. So malnutrition is not having healthy diet, not having balanced diet, not having proper nutrition, whether it is deficiency or excess. Nutritional deficiencies disorders are a major health problem in Indian subcontinent and majority of developing and underdeveloped world countries. In India and Pakistan alone, nearly 63 million children are acutely malnourished. 63 million children, 630 lakhs. In Indo-Pak, every year more than 1 lakh children die, more than 1 lakh. It's not less than 1 lakh. And this is the one documented cases. So if you think about documented cases being 1 lakh, there must be undocumented cases. So the figure must be 2 lakh. So in Indo-Pak alone, every year more than 1 lakh children die directly due to complications of malnutrition. A child is simply a malnourished child. He develops a diarrhea and he dies on the third day of diarrhea. As compared to a child who is previously healthy, who is normal in weight and build, who has no history of any kind of nutritional disorder, that child will not die from a simple diarrhea. But if a child is extremely malnourished, that child may get uh, severely ill and eventually die of simple diarrhea just because of being malnourished. So, at the same time, 1 billion adults are overweight or obese all over the world, while 462 million are underweight. So, all of these are WHO figures. 47 million children under 5 years of age are wasted, 14.3 million are severely wasted, and 144 million worldwide are stunted, while 38.3 million are overweight or obese as well. So if you start combining these figures, so it almost is going to touch half a billion in a couple of years. So 47 million under 5 years of age are wasted. We will talk about what is wasting and what is stunting. 14.3 million are severely wasted and 144 million are stunted as well. While 38.3 million are on the other band of spectrum, overweight or obese. Around 45% of deaths among children under 5 years of age are linked to undernutrition. That is a whopping amount of figure. 45% means that majority of those children who die in hospitals due to various illnesses, whether it is pneumonia, whether it is diarrhea, whether it is some other kind of illnesses, whether it is meningitis, whether it is tuberculosis, almost half of those children die just because they are undernourished and their own body cannot fight with that disease along with the antibiotics and the treatment that the doctors give to them. So these mostly occur in low and middle income countries. At the same time, in these same countries, rates of childhood overweight and obesity are also rising. But basically, childhood obesity and overweight is the problem of developed world. So, major nutritional deficiency disorders worldwide. There are many nutritional deficiency disorders, but there are six major nutritional deficiency disorders worldwide. Number one is marasmus. Number two is kwashiorkor. Number three is nutritional anemias, iron deficiency anemia. Number four is xerophthalmias, vitamin A deficiency. Number five is rickets, bowing of the bones. It is due to vitamin D deficiency. Number six is goiter, enlargement of thyroid gland. It is due to iodine deficiency. So there are six major nutritional deficiency disorders worldwide. So important nutritional problems in underdeveloped world. Number one is protein energy malnutrition. Number two is low calorie intake. Number three is vitamin deficiency disorders. Number four is mineral deficiency disorder. So to cover all of the aspects of malnutrition, we will discuss number one and then number two in today's class. We will discuss protein energy malnutrition and low calorie intake related problems in today's class, and we will not be able to discuss the vitamin deficiency disorders and mineral deficiency disorders in today's class due to the lack of time, because vitamin deficiency disorder is another important topic, and it needs a designated time and specific time. So major causes of malnutrition are poor socioeconomic status being number one. Most of the children or most of the adolescents who are malnourished, even the women who are malnourished, is just because of having a poor socioeconomic status. Then there is another problem, which is lack of basic education regarding healthy diets. Then there are some infections, long-standing infections of the digestive tract, or long-standing infections of some other parts of the body, which take their toll on body. And no matter how much you eat, no matter how much food you intake, the infectious disease keeps eating your calories, keeps eating your body away. And there are some other diseases such as malabsorption syndromes, where the patient is taking normal amount of food, patient is taking good amount of diet, patient is taking balanced diet, but still patient is malnourished, not because of the problem with the nutrition, but problem with the absorption or digestion. So the major cause of malnutrition also include those diseases in which there is the problem with the digestion process. Then there are some cultural influences and inadequate health services as well. Some cultures do not allow the people to take meat products or animal products, so they are vegans. These people also have some mineral deficiencies and protein deficiencies as well, and there are also inadequate health services in majority of the underdeveloped world, which also result in malnutrition problems. Then assessment of nutritional problems. The assessment of nutritional status of an individual involves various techniques. So whenever you are a healthcare professional and you are working in a healthcare setting, it doesn't even matter whether you are a pediatrician, whether you are a doctor or not. If you are a paramedic, if you are a nurse, if you are a ward boy, if you are a midwife working in a pediatric ward, you should know the basic assessment of any children or any kid, how to assess the nutritional problem in a child. It does not need for you to become a doctor. You can be a nurse, you can be a midwife, you can be a male nurse, you can be a female nurse, you can be a ward boy, you can be a voluntary healthcare worker who should know how to spot the nutritional problems. So what I have added in this diagram, it is for healthcare professionals only. So if you become a healthcare professional of any kind, you should know what these things are and how to assess a child with suspected nutritional problems. So the assessment of nutritional status of an individual involves various techniques. First of all, assessment of dietary intake through detailed dietary history taking. You need to ask the parents what do they give the child. If a child is 4 months old, whether he's or she is being given breastfeeding, whether he or she is given diluted cow milk or diluted goat milk, whether he or she is being given formula feed or anything like that. And if a child is more than 6 months of age, whether the proper weaning has started or not, whether the parents have added some solid foods, some semi-solid foods like banana, some porridges, some pulses, some soft diets such as custard, etc. So, whether their parents have added such things in the diet of the child or not, because most of the problems start to arise if the child is being breastfed, then the child remains okay for first 6 months of life. If the diet of the mother is good, if the diet of the mother is good, and a child is being breastfed, the child remains very healthy for first 6 months of life if the diet of the mother is good and her milk is healthy. It's not just water. So the child remains okay for first 6 months of age. But the problems, majority of the problems related with the malnourishment of the children start to arise after 6 months of age because most of the underdeveloped world thinks that up till 1 year or 1.5 year or 2 years of age, child only needs milk. There is no need to give him porridges. There is no need to give him boiled egg. There is no need to give him other dairy proteins or fats. There is no need to give him bread. There is no need to give him fruits. There is no need to give him legumes. There is no need to give him anything. Milk is enough for the child. So the problems, majority of the problems, we're not talking about those children whose mothers are also malnourished. Those children are malnourished from the start because their mother's breast milk is just like water. It does not contain any nutrients because the mother herself is malnourished. So we're not talking
Dr. Omer,
about those children. Yes,
I,
yes.
I heard that a diet of only milk is lacking in vitamin C. Is that true?
Yes, sir. It's true. It's not just vitamin C, there are many other things. Uh, Milk does not contain iron, milk does not contain zinc, milk does not contain manganese. There are many things milk does not contain. Milk is a very good part of diet, but milk is not the sole diet, especially after 6 months of age. No, why do we doctors keep talking about 6 months, 6 months, 6 months? Why do we not talk about 3 months? Why do we not talk about 4 months? Basically, the child which comes into this world, and this is essentially true up till 4 months of age, the child which comes into this world up till 4 months of age, his or her body, that infant, his or her body contains all the reserves of essential vitamins and minerals, especially minerals, which are needed for the first 4 to 5 months of life, which are not present in the breast milk. So the problem arises when the child starts to grow. When the child starts to grow after especially 5 months of age, the iron reserves of his or her body start to get depleted because the iron, all of the iron which was reserved in the body of the child in early infancy gets used up because in first year of life, child grows like it gets double in size at the end of the year, or even sometimes more than double in size. Sometimes a child from 3 kg, a child gets goes to 10 kg within 1 year. So it's more than three times of the size. So what happens? We keep giving him or her the milk. We think that milk is necessary for the child, but we overreact and we think only milk is necessary. That is the problem with underdeveloped world. That is the problem with developing countries. That is the problem in India, Pakistan, Bangladesh, Sri Lanka, because I belong to this part of the world. But I can think that African countries and sub-Saharan Africa or Southeast uh, South America, or even poor countries of the Europe as well. So I think majority of the people in these countries, not only in these countries, there are many other countries as well, think that child only needs milk, and that is the root cause of the problem. So we will discuss all of these things as well. So the assessment of dietary intake through detailed dietary history taking, I just took my time over this slide because this is very important. History taking is very important, and you yourself need to know about the problems as well. Because if you do not know what to give, you do not know what to ask. So if you do know what to give, then you will start asking the exact questions which need to be asked by to the parents, especially the mother. Detailed dietary history taking pertaining to specific food consumed, its amount, quality, and adequacy in relation to nutrient value. In young children, head and chest circumference are important to assess for growth and development or deviation from normal. So basically, head and chest circumference is standardized all over the world. So there are some standards made by World Health Organization and World Pediatrics Association. There are association of doctors. They have made some basic standards that a child of 1 month of age should have his head circumference of this centimeter, and a child of 3 months of age should have his head circumference of 95 centimeter. I'm just giving an example. And similarly, a child of 1 month of age should have his chest circumference of this centimeter, and a child of 3 months of age, and child of 6 months of age, and child of 9 months of. There are some normal ranges. It's not like the exact number of centimeters. There are ranges, normal ranges. A child may be touching the lower normal or maybe touching the upper normal limit, but it will be considered normal as far as the child is within normal ranges. So there is a concept of standard deviation as well, but it's not the time to go into the statistical details of what are the standard deviations and etc. because it will go out of the scope of this lecture. But basically, there are some standards of head and chest circumference guided to everyone. There are charts available in every pediatric ward. So we just take the children in our hand, we just measure the head circumference, and we take the we ask about the age of the child, and when the age of the child is in front of us, what we do, we compare the head circumference of that child with the normal value of 3 months of age child. So if we say we are getting 96 centimeter, we take it and go towards the chart whether 96 centimeter is lying within the normal limit. Okay, it's in the normal limit, so the height circumference is normal. So that's the way. Then there is anthropometric measurements. Anthropometric measurements are like anatomical variables. It's like weight, length, height, mid upper arm circumference. So this is MUAC, MUAC, mid upper arm circumference of left arm. So this is the thing which this is the measurement which we take usually when we are screening young children for malnutrition. So we take mid upper arm. So this is arm, and we take the mid of upper arm in between the shoulder joint and elbow joint, just mid of it on the left side. So we take the measurement of this, and what is the significance of this measurement? I will talk in detail in our next slides. And then there's BMI, body mass index for adolescents results. Then there is clinical exam of the child to assess deficiency signs and associated problem. It involves thorough head to toe examination to detect classical signs of various deficiency signs, such as if a child is severely pale, is having anemia, and the most common mineral deficiency problem in all over the world, especially in developing and underdeveloping world, is iron deficiency anemia. We keep giving the child extremely iron deficient foods. We do not give them red meat. We do not give them any red beans. We do not give them green leafy vegetables rich in iron. So what is the end result? Almost 80% or 70% of the children in underdeveloped or developed world today are deficient in iron, resulting in iron deficiency anemia. Then there is assessment of associated problems. So whenever we take a child and we are suspecting the child to be malnourished, we should also think about TB, because there is a condition called tuberculosis in which within 3 to 4 months of age, the patient loses a lot of weight. Even if the patient is taking normal diet, the patient loses weight. So there is no problem with the nutrition, there is no problem with the digestion, but the disease itself is eating away all of the energy reserves of the patient. So we have to think about the tuberculosis as well. We also have to think about the malabsorption disorders. I will not go into the details of malabsorption disorders because it will go out of the scope of this lecture. But there are some malabsorption disorders such as celiac disease, in which patients cannot digest gluten containing carbohydrates. So, whenever they take gluten containing diet, their intestine gets inflamed and they start getting diarrhea and etc. And whatever they are eating, it does not get digested. So, no matter how much they eat, it does not get digested. So, the patient becomes nutritionally deficient in many things. There are also cultural food related taboos as well. Example given in some cultures, children should not eat eggs. It is considered that children should not eat eggs as they may become chicken thieves. So there are some cultural related taboos as well, which make our children protein energy deficient as well. So as we discussed in our previous
Dr. Ahmed,
slide,
there's
yes, sir.
a quick question in chat. If a
Okay.
child loses his,
Actually, I do not look at the chat because of the concentration, because I want to end it right now. But okay, you can ask question.
just if a child loses his mother during birth in those first few months, how can the
Oh my
child
God.
maintain good nutrition?
Okay, can I answer it at the end of it?
Oh,
Because
yes,
right now,
thank you. Sorry.
we are seeing this problem in Palestine as well, because there are almost 13 to 15,000 mothers that have died in Palestine, Gaza. So I will touch it. So there is a acute problem going on in this world, and the world is just watching, and we are not doing anything. So basically, this is a very good question. There are many parts of the world where uh, mothers get ill, but there are many parts of the world where mothers they just die because of the wars and the sufferings of the war. So yeah, I will touch it at the end of the question, at the end of this lecture.
Thank you.
Mid-arm circumference is the circumference of the left arm, where at midpoint between the tip of the shoulder and tip of the elbow. I will increase my speed because the topics that we are going to cover in the topic that we are going to cover are very important. MUAC or MOAC is used for the assessment of nutritional status. It is used for children between 6 and 59 months of age. It is also used for assessing acute energy deficiency in adults during famines as well. BMI, on the other hand, is a measure for indicating nutritional status in adults. It is defined as a person's weight in kilograms divided by the square of the person's height in meters. You already know all of these things. I will not go into details. For example, an adult who weighs 70 kg and whose weight is 175 meters will have a BMI of 22.9. Body mass body mass index Z scores, also called BMI standard deviations, are measure of relative weight adjusted for child's age and sex. So the first problem of malnutrition of the developed world is overnutrition and obesity. We are overfeeding ourselves or our children or our families. Overnutrition is a form of malnutrition, imbalanced nutrition, arising from excessive intake of nutrients, leading to accumulation of body fat that impairs health. That is, if we become overweight or we become obese. For adults, WHO defines overweight and obesity as follows. Overweight is a BMI greater than or equal to 25, greater than or equal to 25. And obesity is a BMI greater than or equal to 30. For children under 5 years of age, overweight is weight for height greater than 2 standard deviations above WHO child growth standards median. So basically, there are some child growth standards. I have already told you the basics of what a child growth standard means. We have some charts present in pediatric ward, in pediatrician clinics, in pediatrician nursing setups that We have these standard deviations. We have everything in our hand. We just have to measure the weight of the children and just compare it to the normal limits of the uh, child weight in that age bracket. For example, if we have a 6 year age, if we have a 5 year, if you have a 4 years old kid who comes to our healthcare setting, and we measure the weight of the child, and the child looks like just like this chubby kid which I have shown in this picture, and we just by the look of it we know that the child is overweight or obese. We just measure the weight of the child and compare it with the standard deviations and the standard medians of growth standard medians provided to us by the WHO guidelines. So while obesity is weight for height but is greater than three standard deviations above the WHO child growth standards median. So if there is two standard deviation difference on the up limit, then we will call the child as overweight. But if there is a difference of three standard deviation above the WHO child growth standards median, then we will call the child as obese. So pathophysiology of obesity, there is genetic predisposition, diets largely derived from carbohydrates and fats, then protein rich food. There is sedentary lifestyle, conditions, example given hypothyroidism, Cushing syndrome, insulinoma, bulimia nervosa, hypothalamic disorders, and fatty liver is very common in obese individuals. There is increase in size, number of adipocytes. Adipocytes are basically fat cells. Fat cells, and there is hypertrophy as well as hyperplasia of fatty tissues in obese individuals as well. So metabolic changes in overweight and obese individuals. One can develop hyperinsulinemia, non-insulin dependent diabetes, hyperlipoproteinemia. Hyperlipoproteinemia means increased cholesterol levels in the blood, which leads to many problems, which leads to clot formation in the arteries and strokes and many problems. Then there is problem of daytime somnolence or sleep. I will not go into the pathophysiology of daytime somnolence or sleep. Why does it occur? Because it is another topic, but there is a problem of daytime somnolence or sleep in excessively obese, obese class 2 or obese class 3. Patients having BMI of more than 35, they start suffering from this problem of daytime somnolence or sleep. Then there is a problem of snoring. The snoring starts with the fat neck problem. Whenever a patient becomes so fat, so overweight that their neck also becomes full of adipose tissue, then they also start snoring due to the difficulty in breathing while sleeping. Then there is hypercapnia. So hypercapnia is high concentration of carbon dioxide in blood. And there is also a pathophysiology for the hypercapnia, but I cannot go into the details. But there is a problem of hypercapnia in obese individuals. Then there are the risks of coronary artery diseases due to the arterial plaque formation due to hypercholesterolemia, hyperlipoproteinemia. There is excess of cholesterol, there is excess of lipids in all over the blood stream. Then there is polylithiasis. Polylithiasis means gallbladder stones. So there are stones in gallbladder, then there is risk of cancer. Atherosclerosis, osteoarthritis, so joints starts tearing because the joints are able to carry weight up to 80 kg or 90 kg. But if we become 130 or 140 kg, our ankle joints and our knee joints starts to give away. They are not able to take weights more than 90 kg. Our joints are not built to carry 100 kg or 110 kg or 120 kg of weight. So whenever we become overweight, our joints start disintegrating. And that problem is called age-related joint degeneration related inflammation, and it is called osteoarthritis. It also causes complications of heart, thereby reducing life expectancy. Then there are psychological consequences as well. Obese patients become depressed as well because many of the times they also people also get amused by teasing such people. Management of overweight and obesity is a behavior and lifestyle modification. Obesity control sport groups where exercises and activities are promoted and dietary guidance is given to peers. Medical management is drug therapy. There are some appetite suppressing drugs, but these drugs have their side effects, so they should not be used without doctor's prescription or health professional supervision, such as controlling, etc. Then there is surgical management as well. there are many parts of the world where surgical management for extremely obese people, obese class 3 or obese class 2 people is being done. Ventricle banded gastroplasty, adjustable gastric banding, or laparoscopic bariatric surgery involving gastric resection surgeries. So parents should reduce and in children, what we need to do, parents should reduce inactivity in children by limiting television and computer games, encourage children to walk instead of being driven to and from school, and to actively play with their friends for 30 minutes to 1 hour daily. And play with their friends does not mean video games. Play with their friends mean physical games like football, hockey, badminton, whatever. It's not like playing video games. So, undernutrition and protein energy malnutrition. So, undernutrition, we were discussing overnutrition, now we are discussing undernutrition. So, undernutrition is a deficiency of calories or of one or more essential nutrients. So, undernutrition is a deficiency of calories or there is a deficiency of one or more essential nutrients. Undernutrition may develop because people cannot obtain or prepare food, have a disorder that makes eating or absorbing food difficult. So cannot obtain or prepare food occurs in extremely famine hit areas, extremely drought hit areas, or war zones. So, cannot obtain or prepare foods. Just like people in Palestine, they are forced to eat grass leaves. So, why is this happening? Because this is a war zone where the food supply has been stopped due to the conflict in the Middle East. So, what is happening? People cannot obtain or prepare food. There are no basic ingredients. There is no tomato, there is no meat, there are no pulses, so they cannot obtain and thus they cannot prepare food. Then there are people who have eating disorders who do not eat properly because they are always thinking about whether they will get sick or not. Then there is also problem with the food absorption as well. So then there is a great, and then there are people who have greatly increased need for calories, as of course during periods of rapid growth from ages of 12 to 16 years. Then there are four broad subforms of undernutrition: wasting, stunting, underweight, and deficiencies in vitamins and minerals. So low weight for height is known as wasting. So if a child is having normal height but he's underweight, then that child is suffering from wasting. It usually indicates recent and severe weight loss because a person has not had enough food to eat or may have suffered diseases such as severe diarrhea. So, if a person suffers from chronic diarrhea for more than 3 weeks, he starts losing weight at a very rapidly. Within a couple of weeks, the patient, you will see and you will not be able to recognize the patient. The patient will have lost 10 kgs or 12 kgs of weight, and you will look at him or her and you will be in shock. What happened to you? I just had diarrhea. So, because the problem with the diarrhea is whatever you eat, it will not get digested properly. So, they are at an increased risk of death. So, low height for age is known as stunting. So, wasting is basically you have your normal height. So, if a child is 10 years of age and his height is normal, just like other 10 years of age children, that person will not be called stunted child. That person will be called wasted child because that child whose height is normal as compared to other 10-year-olds, but the weight is less. So we will call it wasting. But what is stunting? It is the result of chronic or recurrent undernutrition. So when there is chronic undernutrition, not some acute problem, usually associated with poor socioeconomic conditions, poor maternal health and nutrition, frequent illnesses and inappropriate infant and young child feeding and care in early life, the child suffers from stunting. So first 5 years of life are very important, and especially first 3 years of life. So if a child is not taken care of in first 3 years of life, and then in first 5 years of life, chronically, like always, that child will suffer from stunting. It will be very hard for that child to achieve normal height, even if we start giving them very good diets after 6 years of age or after 7 years of age because the damage has already been done. So, the children with low weight for age are known as underweight. A child who is underweight may be stunted, wasted, or both. So various forms of undernourishment are not, first of all, on the most left side is a normal child. So normal weight and height child. Then there is a wasted child whose height is normal, but he suffer from some acute illness or some acute malnourishment due to being stuck in some war zone, due to being stuck in some famine area, some drought hit area. The person has suffered from acute malnutrition, but his bones will not erode, so his height will remain same as normal people, but he will get wasted. Then there is a child who is shorter than normal, who is stunted. His weight is normal, but he is stunted due to chronic malnutrition problem, due to chronic malnourishment. Then there is a child who's wasted and stunted as well. He is thinner as well as shorter than normal as well. And that child is very difficult to treat. So triage of children with malnutrition, acute malnutrition in children, there are some, there is an algorithm. So if a child is with complications such as there is edema, so edema is basically severe protein deficiency or marasmic kwashiorkor, and there is mid upper arm circumference of less than 125 millimeter or 12.5 centimeter or bilateral pitting edema, and one of the following such as anorexia. Anorexia means loss of appetite, low respiratory tract infection. So the child is also suffering from pneumonia. There is high fever, severe dehydration, severe anemia, not alert. Hypoglycemia means low blood sugars, and hypothermia means low body temperatures. The child needs to be admitted. That child cannot be sent home. If you see a child who is suffering from any of these complications and that child is malnourished, you cannot send that child home. It's a crime to send this kind of infant or toddler or young child, school going age. You cannot send that kind of child home. You need to admit that child in a child stabilization center where the children with malnourishment problem or acute malnutrition problems are treated. So that child cannot go home because that child can die anytime. And then there are children who are acutely malnourished but without complications. Their mid upper arm circumference is less than 125 millimeter. There is edema, but their appetite is good. They're, they are clinically vitally stable. They are not in shock. They are not having high fever. They are not showing any signs of dehydration. They have no sunken eyes and they are alert, playful. Then you can keep those children under observational programs. And what is this? That observational program? There is outpatient therapeutic program. Every week, every fifth day, the child has to be brought to the healthcare setting so that the pediatrician or general practitioner or a pediatric nurse can look at the child and assess his nutritional status week to week basis. Then there are children whose mid upper arm circumference is less than 12.5 centimeter, but there is no edema. So edema means there is no protein deficiency, and their appetite is good. They are clinically well and they are alert. Then there are these children are enrolled into the supplemental feeding program. So what is supplemental feeding? I will discuss later. So now we'll come to the protein energy malnutrition. So the group of clinical conditions, signs, and symptoms that result from various degrees of protein deficiencies. We are already short of time. So and calorie deficiency in the diets of individuals. So clinical signs and symptoms of protein energy malnutrition include food weight gain and slowing of linear growth. So the weight gain is also poor and the height increase also becomes slow. Behavioral changes. The child is irritable, apathic, decreased social responsiveness, anxiety, and attention deficit problems. Then there is atrophy of muscles, and there is weakness of skeletal muscle, including the respiratory muscles as well, reduced heart muscle mass as well, impaired wound healing, skin thinning with the predisposition of decubitous ulcers, immune deficiency problems. The child gets sick every now and there is general fatiguability. The mother tells that the child does not play, does not want to play. Whenever he goes to play, day he says that he is having pain in legs, he cannot play, he does not have the energy, he cannot run properly, he cannot play for more than 5 minutes. All of these things are signs and symptoms of protein energy malnutrition. So there are three clinical syndromes of protein energy malnutrition. Number one is kwashiorkor, number two is marasmus, and number three is marasmic kwashiorkor. So what is kwashiorkor? So kwashiorkor is protein malnutrition predominant. So the problem with the kwashiorkor children is protein deficiency. And what is the problem with the marasmus children? They are deficiencies in all of the calories. So they are not taking any of the carbohydrates, proteins, or fats. They're not taking anything. So that children is suffering from marasmus. And the person who is suffering from severe protein malnutrition, the person is not taking proteins, only taking carbohydrates or fats. That child is suffering from kwashiorkor. Then there is third spectrum called marasmic kwashiorkor baby. It is marked protein deficiency and marked calorie insufficiency signs. It is the most severe form of malnutrition. So the classification of protein energy malnutrition is primarily clinical. So it is a clinician who will decide whether the child is suffering from kwashiorkor, marasmus, or marasmic kwashiorkor spectrum. Anthropometry and other clinical changes. Some children fall in between the two forms and suffer growth failure but exhibit no signs of either disease. So there are some children who fall in between the both forms, varying degrees of nutritional problems. Sometimes they do take protein, sometimes they do not take protein. So they fall in between. So then only experts can identify the problem with such children. So what's your core? We will just have a brief whiff of it, because most of you people already know. Many of you people must have read this disease in your school, high school age, and then college life as well. So kwashiorkor is a type of malnutrition characterized by severe protein deficiency. Remember it. Severe protein deficiency. It causes fluid retention, edema, and a swollen abdomen. So clinical manifestation of kwashiorkor are protruding belly, brownish hair, dark and scaly skin with hyperpigmentation. So they are red babies. Stunted growth, underweight, swollen legs. Sometimes they even gain weight as well due to fluid retention, but mostly they are underweight. Swollen legs and pitting edema, loss of appetite, mental retardation, and very severe anemia, reduced resistance against infections, heart failure, and decreased albumin level. Albumin is the basic protein that is present in the blood. So if a child is not taking proteins, his blood albumin levels, blood protein levels will be less, obviously. So in the round face or moon face baby, there will be muscle atrophy, abdominal distension, edema, there will be growth retardation. The child will be 7 years of age, but he or she will look like 3 or 4 years of age. There will be thinning of hair. The hair will not be healthy at all. There will be inflammation of the skin, dermatitis as well. And if you get an ultrasound scan of that child, there will be fatty liver as well. So the causes of kwashiorkor are mostly present in preschool children in poor countries. Social and economic factors include poverty, ignorance in the parents, inadequate weaning practices. There is no proper weaning. They keep giving only one kind of diet to the children. They keep giving only bread, only bread, only bread, only bread, and there is no specific form of protein given to the children. Then there is child abuse. The child is being tortured at home. The child is being not given proper food at home, or any child care setup, or whatever, whether it is an orphan home or some adopted case. So there is cultural, and there are some wrong cultural and social practices as well. The family may be vegan, so the vegan people, not all of them, but the vegan people, majority of them also suffer from protein energy malnutrition. Then there are lack of nutritional knowledge to the parents as well. And then there is management of kwashiorkor. So basically, you need to give more calories and protein, not just calories, protein as well. Treatment depends on the severity of the condition. Children who are in shock need immediate treatment to restore blood volume and maintain blood pressure. IV fluids, empirical antibiotics must be started, such as ampicillin or gentamicin, etc., because these children are prone to get sick whenever they are admitted in any healthcare setting. So you have to start empirical antibiotics, then you have to give IV fluids must be started immediately along with protection from hypothermia. These children are hypothermic. These children's body temperatures are low and they may die because of low temperature. So you have to warm them adequately. Calories are given first in the form of carbohydrates, simple sugars, and simple fats, not some complex carbohydrates, not some complex fat meat. Then vitamins and mineral supplements are started hand in hand because whatever you are giving, they must be deficient in vitamins and minerals as well. So they will not be able to properly use the sugars and fats which you are giving them. Foods must be reintroduced slowly. Oral foods must be reintroduced slowly. You do not just give them, start giving them oral foods like as if they are hungry from just 2 days. They are hungry from ages and their body may not even accept the food given to them. Carbohydrates are given first to supply energy, followed by proteins, foods gradually, because proteins are a little bit harder to digest. NG feeding can be considered in children who are unable to chew or swallow properly. NG feeding, if you people do not know, is nasogastric feeding. So basically, we pass a tube from nasal cavity directly into the stomach. I do it in routine because of being in a critical care setting. So basically, what we do with the patient, if a patient, we think the patient is unable to chew or swallow, or if patient is very weak, and if a child is very weak, we pass an NG from nasal cavity directly into the stomach and start feeding the child or start feeding the patient directly through NG feed. We cannot give solid diet through that, but we can give in the form of shakes, in the form of semi-solid, loose semi-solid diets can be passed through an NG tube. Then there is an marasmus. So marasmus is energy and energy deficiency disorder of all macronutrients, carbohydrates, fats, and proteins, resulting in lack of calories. They lack all nutrients. Marasmic children are grossly emaciated due to wasting of muscles and subcutaneous fat, having weight for age less than 60% of reference median, and may be stunted and have no edema. Just look at this picture and you can understand that child is a marasmic child. That child will have an old person's face. Even if a 4 years age child comes to you, you will think that as if a child is 12 years of age. He will look like an old person due to loss of fat and loss of baby's features. Marasmic children are grossly emaciated. These children are often irritable and unlike children with kwashiorkor may have good appetite for food. The skin and hair are usually dry and depigmented. In kwashiorkor, the skin is pigmented, but here the skin may be depigmented, and the hair is usually sparse. So the hair is usually sparse in both conditions. When children with features of marasmus have edema, they are classified as marasmic kwashiorkor babies, which are even more difficult to treat. So the clinical manifestations and risk factors are causes of marasmus. So on the left side, there are clinical manifestations. The weight of the child drops to 60% below the expected weight for age. Muscle atrophy occurs. The child becomes thin, just like if you look at this image, this diagram, the child is extremely thin. It's just like flesh on skeleton. There is no muscle mass, loss of subcutaneous fat, where the arms and legs are thin, wrinkled, and flaccid skin. The face of the child looks like old person and anxious. The child may have diarrhea or constipation as well. The child has very good appetite when fed, with no increase in weight, alert but miserable and hungry, wrinkled skin. What are the risk factors or causes for marasmus? Inadequate intake of all of the calories and nutrients, illnesses and infections, long-standing illnesses and infections. Then there are some environmental factors where there are cultural practices resulting in the lack of nutrients, essential nutrients in the diet of the children. Then there are lack of access to sufficient and nutritious food, such as in famine-hit areas, drought-hit areas, or especially in war zones. So we already listened to this that the children suffer a lot in wars, inadequate breastfeeding or nutrition in infancy, such as the mother has died during a war or during an illness or during an accident. So the child suffers just because of the death of the mother, and then there are underlying health issues as well. So the management of children with marasmus also correlates with what the management with kwashiorkor looks like. There is constant monitoring. Ideally, with marasmus should be isolated from other patients, especially children with infections, because if any children with infection, healthy person, children with infections come near to the patient with marasmus, that patient with the marasmus will not be even able to bear simple sore throat. The child will die of simple sore throat. So if a healthy children is with infection, he or she should not be allowed to go to the marasmic child. Then the treatment areas should be as warm as possible, and bathing should be avoided to limit hypothermia. Therefore, the hospital structure should be best adapted for the treatment of severe malnutrition. In cases of shock, IV rehydration is recommended using a ringer lactate solution. What is ringer lactate solution? All the healthcare people do know about it. Then with 5% dextrose, it's basically dextrose is a common sugar or a mixture of sodium chloride and 5% dextrose. It is called PEEP7. The following rules should be implemented in the initial phase of rehydration. Use an NG tube. Continue breastfeeding except in cases of shock or coma. If the child is not in shock or coma, the mother should continue breastfeeding because it helps the child. Start other foods after 3 to 4 hours of rehydration. First of all, the child should recover, and after 4 hours, if the pediatrician or the nursing staff deems it feasible, then there should be some other food given to the child, but not before the counseling or not before asking the healthcare professionals. Then there is an algorithm. I will not go into the details of this algorithm because this algorithm is a little bit complex for common folk. It is a little bit complex for those people who are not doctors or who are not specialized nurses or specialized healthcare staff. Now, but there is an algorithm, and I had to add it. It is a very helpful algorithm. It is a very helpful schematic diagram, many schema for the children who are not malnourished or who are very mildly malnourished and who are moderately. Ma'am is basically moderately malnourished child. This is ma'am. It is basically moderate acute malnutrition. Then there is a SAM baby, which is severe acute malnutrition but without complications. Then there is a SAM baby, which is with complications. So there are different management guidelines for all of this, and you people need to understand, and you people need to read on your own behalf. Because if I start going into the details of this diagram, it will take another 15 minutes. Then, our last topic for today is approach towards a child with life-threatening severe acute malnutrition. So, if we encounter a child with life-threatening severe acute malnutrition, then we need to go IV. We need to go intravenous. Parenteral fluid means we have to pass an IV line, we have to maintain an IV line, and we have to give fluids parenterally. And give oral feeding as well. If able to take orally, only then give orally. Otherwise, pass an NG tube, nasogastric tube. Keep the child warm. It is very important. That's why I have repeated this in my next slide as well. So keep the child warm, maintain the body temperature within normal range, provide rest, appropriate activity and stimulation, recording feeding, fluid intake and output charts, daily weighing. Yeah, we need to weigh the child daily. Frequent turning and preventing infections. Carefully observe infants. Infants are those children who are under 1 year of age. Toddlers are from 1 to 3 years, and infants are those children who are under 1 year of age. So carefully observe infants for infections of mouth, skin, respiratory, and genital unitary infections. The infant is protected from other patients and caregiver who have infections since they have low immunity. So if you have an infant with severe acute malnutrition, he is an abused child, or he is a child from some war zone or some famine hit area, then that child should be isolated from other people. Even if a person is suffering from flu, simple flu, that child who is low in immunity and severely acutely malnourished, that child can die from simple flu within 2 days. So if you are suffering from a simple flu, you are not allowed to go to a near to 6 feet to that child who is severely acutely malnourished. Infant may also have emotional deprivation as well. Stimulate child and counsel the caregiver about emotional attachment as well. kiss the child, hug the child, keep loving him or her, so that emotional instability also decreases. The approach towards the child will have threatening severe complications, severe acute malnutrition continued. One should begin with milk products, which may have to be diluted as well. Observe for milk intolerance in such children as well, because there are children who cannot digest lactose. So you have to give lactose-free milk in such children as well. As the patient condition improves, undiluted milk, sugars, oils, and vitamins should be given. A high calorie food should be commenced after 2 to 4 days, with solids being cautiously and slowly introduced. You start with semi-solids, you start with milkshakes, you start with other easy to digest semi-solid foods, and then after 4 days you start with the solids. As child's condition gradually improves, then the NG tube is removed and a spoon and cup is introduced. The parents should be involved in the feeding under the instructions of the nurse or any healthcare provider. Feeds should be given at 2 to 3 intervals, and later as the child improves, the feed can be increased and given for hourly as well. Then there is prevention of undernutrition. So this is our last slide. Provision of balanced diet. So I just touched it. I will go into the details of how to prevent all of these problems. We will discuss this public health problem in details in our next lecture, but I had to touch it in this lecture as well. So the provision of balanced diet with adequate protein and energy, food fortification, example given iodized salts, immunizing against vaccine preventable diseases, periodic health checkup for all children for nutritional supervision, detection of growth failure should be commenced as early as possible. Then there should be nutritionists to provide food for the poor families. Then there should be parent counseling and education on infant feeding and care for prompt treatment for congenital defects as well. Promotion of exclusive breastfeeding up to 6 months of age where possible. Appropriate weaning practices give necessary nutritional supplements to the poor parents as well. Improvement of health of pre-pregnant mothers. Yes, improvement of health of mothers is very important. Improvement of health of pre-pregnant mothers, pregnant mothers, and lactating mothers. Because if the mother who is pregnant and who is lactating her child, and the mother is not being given proper diet, the child will suffer from the problem with the mother's diet as well. The child will also become malnourished along with the mother. Improvement of family dietary habit with locally available low cost food items for a balanced diet. Locally available low cost food items. Yeah, this is very important. We do not need to buy some imported food stuff. We do not need to buy Nestle products. We can make porridge at home. We can make cereals at home. We can make purees at home. There are many YouTube channels helping mothers all over the globe. There are many YouTube channels which are helping mothers who want to learn how to make a good puree, how to make a good porridge, how to make a good cereal for your infant, for your toddler. What to do if your toddler is ill? What to give if your toddler is not eating this? What to do if your toddler is not eating that? How to give milk, how to prepare a cereal at home, how to prepare a puree at home. There are many YouTube channels, but we need to find them. Nutritional education and counseling to promote correct feeding practices, food habits, hygiene, safe water, environmental sanitation, eliminate misconceptions regarding food and feedings, promotion of educational status of women to improve the family health. Yes, last line was the most important line. Promotion of educational status of women. Promotion of educational status of women to improve the family health. Because if the mother does not know what to give to her child, the whole family will suffer. The whole family suffers. Because if mother does not know what to eat, if mother does not know what to give to the children, the whole family suffers. So therefore, the educational status of woman is very important in family health. Yes. Have a nice day. Thank you.